I'll just wave and say hello everybody, hello Manitobans, and we'll launch right into it because I usually take an hour and a half to do this presentation and I go overtime. So we'll need to motor. But this is an opportunity just to go over some of the basic information about dementias, the different types of dementias, a little bit about what is known about what causes them, how we try and make the diagnosis, and then some about the treatments, focusing on the doctor type treatments, which is, face it, the smallest part of the treatment, but other sessions cover the important management of all the troubles with dementia. So we'll start at the beginning with some definitions. So the most common question I get asked about it is what's the difference between dementia and Alzheimer's? So here's the answer. So dementia is a syndrome, which means a collection of signs and symptoms that often is maybe caused by more than one disease. So and that's true for dementia as well. So the symptoms for the dementia syndrome is often, not always, but often memory loss, but also other aspects of thinking. It is a brain syndrome, so it's all about problems with thinking. So memory is part of it, but also judgment, reasoning, how people behave, their initiative, and other symptoms that we're going to cover in a little bit. For us to consider these symptoms to be bad enough to call it a dementia, they have to be affecting the person's functioning. So it's not just a minor thing like forgetting where your keys are, that's pretty normal. But if you believe somebody has stolen your keys, hide them, and then forget where they are, and that happens 15 times, then that's affecting your day-to-day function, for example. Or if your memory is so bad that you can't keep appointments, or you can't remember to take your medications, or you get your finances mixed up, and so on. So it has to be affecting some aspect of your function in some way. There's various things that can cause the dementia syndrome symptoms. Some of them aren't dementia, like depression or low thyroid. Infections causing dementia is pretty rare now, except for HIV. It used to be syphilis, but that's very rare now, fortunately. There are some medications that can cause memory problems that we'll come to later. But if it really is a dementia, that's going to be something wrong with the brain. A lot of the dementias are degenerative, which means that it's progressive or damage that's worsening in the brain over time. If you have memory and thinking problems bad enough to affect your function, that's not a normal part of aging. Some mild changes in memory with aging, though, is normal. But if it gets to the point of affecting what you can do or not do from day to day, then that's more of a worry. Like any other aspect of life, with dementia, each person is different. So although we can describe the common symptoms of the dementia syndrome, no two people will go through the whole thing exactly the same way. So dementia is common, and this is just some data, a lot of which was obtained from the Canadian study of health and aging back in the 90s. And it is an age-related disease, so the older you get, the higher the risk of having dementia is. So that's the bad news. The good news is that even if you're really, really old, like over age 95 or 100, so you have a 50% chance of having dementia. So that's bad, but there's a 50% chance even at that ripe old age that you don't have it. So that's the good side of it. It used to be thought that dementia was an inevitable consequence of aging, and it isn't. It's just a very common age-related syndrome. So at age 65, when we traditionally start to threaten to call people old, but they're not really old, only 1 or 2%, so it's a very low risk at that age. But the more years you accumulate past that, the higher the risk gets. And that first line, we forgot forgot to correct that. That means Alzheimer's accounts for 64% of all dementias. But dementia itself is very common in the Canadian population, so almost 500,000 in 2008, so that'll be over 500,000 by now. And as the proportion of the population over age 65 increases, the so-called gray wave, the baby boomers, the oldest one is now 67. We'll have a lot higher proportion of the population having dementia unless something happens to the incidence. And it's, in addition to being a bad disease, and it's an expensive one. So there's some figures there that it has a lot of direct and indirect costs in the Canadian economy. So that's dementia in general. So then what's Alzheimer's disease? Well, that's one disease process that is the most common cause of dementia. So that one's about 2/3 of all dementias in Canada. And with Alzheimer's disease, it starts gradually and gradually gets worse. It does affect memory, judgment, reasoning, and a few other areas of cognition or thinking that we'll get to in a minute. And again, it has to be bad enough to affect your ability to perform day-to-day functions in some way. Why is it called Alzheimer's disease? Well, this is Alzheimer. So he was a psychoneuropathophysicist back in the day, when they only had a few specialties, so he did it all. And he published a case of a very young, for Alzheimer's, we now know, a 57-year-old woman who died with a very premature dementia. And what he'd done was the autopsy with the microscope findings, and that's why his name got attached to it. So that was the first reported case with pathology. And this is the pathology. This is where I usually say, don't worry, it won't be on the test, because there is no test. The pictures on the right are the microscope ones, and at the top, that's a picture of a plaque. And at the bottom, some of the little arrows are pointing at tangles. So they're neuritic plaques and neurofibrillary tangles. So that's the pathology changes you can see. On the right-hand side, at the bottom, is a cross-section through two brains. The one on the left. Yeah, you guys, my physics is challenging me now. You guys are looking at the same screen, so if we're standing in the same room, I have to switch the sides, you see. It's very complicated. Anyway, the normal brain has N at the bottom, so that's a giveaway. And the one with AD, or Alzheimer's disease, on the right of that picture, you can see it's shrunken, so that's called atrophy. But the little arrows at the bottom are pointing to what's called the hippocampus, which is the memory part, the short-term memory part of the brain. And that part in particular is shrunken on that picture. So that's one of the things that happens in Alzheimer's, is more atrophy, and it affects some parts of the brain more than the others, including the memory part. But there's other things that can cause the dementia syndrome, and we're going to talk about them a little bit each. So vascular dementia is from strokes, and then there's other neuropathos, psychophysiologists back then. So Louis, Pick, Creutzfeldt, Jakob, and Huntington all got dementias named after them for similar reasons. And we'll talk about some of them after we talk more about Alzheimer's. So unfortunately, still at this stage, at this time, Alzheimer's is progressive, degenerative, and irreversible. Meaning progressive, it gets worse over time. Degenerative, that just refers to something's happening to damage the nerve cells in the brain. And I'll get to what we think might be happening to cause it. But overall, we just don't know 100% what causes Alzheimer's. And perhaps as a result of that, we still don't know how to cure it or even reverse the damage or stop the damage once it's started, unfortunately. People are sure working on it, though. You can subdivide Alzheimer's disease genetically into two subtypes. The one that's strongly inherited is called familial autosomal dominant Alzheimer's disease. So that, which is the minority of cases of Alzheimer's, has a 50-50 inheritance chance. But the more common kind, that's 95% of people with Alzheimer's, we call sporadic, or it's just not autosomal dominant. So there the family inheritance risk is lower. So people with regular Alzheimer's disease may have a family history, and family history is a risk factor. So the more family members a person has that have had Alzheimer's does increase their likelihood of getting it. But even if you have several people in the family who've had it, unless you're in one of those families that have the familial autosomal dominant version, the risk still won't be as bad as 50-50. So it's bad enough as it is, but at least it's not 100%, like something like Huntington's disease. And then, as I mentioned, there's the minority have this strongly inherited version that's caused by just one gene, but that's not most cases of Alzheimer's. And if that gene is in your family, you have a 50-50 chance of getting it. So we've sort of touched upon inheritance and family history and genetics as one of the causes, and it's likely part of the picture, but it's not. It doesn't explain everything. And I guess we do still have to say that the exact cause of Alzheimer's disease is still unknown. But there's a vast amount of research going on, not least because whoever discovers a cure is going to be rich and have a Nobel Prize. So lots of incentive to research it. But what they do know now is that a lot of things about the pathophysiology or the molecular causes. So one thing they know is that those plaques that we saw on the microscope slide, which are one of the pathologic findings of Alzheimer's, are full of this stuff called beta amyloid. So that's an abnormal glycoprotein. It's not supposed to be there. You can have normal amyloid, but it's not beta. And if your amyloid is beta, it clumps together, and that's part of what is in those plaques. Now there's other things in the plaques as well, but people have been focusing on the amyloid, wondering if that's the actual cause. And part of the reason they think that is some of those families that had the strongly inherited version, they found the genes, and they found the enzymes that those genes make, and those enzymes make beta amyloid. So that's the one direct clue there. So in those few families where they found these genes, amyloid must be part of the cause. But whether it's the cause in the other 95% or a bystander or an accident that comes after the fact is still not known for sure. There's a whole other protein called tau. It's hyperphosphorylated tau, if you'd like to know, in the tangle. So again, everyone's supposed to have tau, and this is abnormal tau. So other people are looking at maybe that's the cause and the amyloid is secondary. Or maybe you have to have them both, or that, like I say, they still don't know. There's other things that go on. There's inflammation and oxidation and other things that damage brain cells. Another thing is that for the beta amyloid to stick together, it has to aggregate, and there's things that help it aggregate. So these are all targets for research as to things that might work as a cure. So far, haven't found it, but they're sure working on it. The normal tau is very important to our cells. Our cells are full of these little microtubules, which are basically the little email and courier system inside the cell. So you need that for your cell to work. But this abnormal tau makes these tangles and it kills off the cell. So that's the one approach to trying to find the cause, is the molecular biology. Another cause is to look at statistical risk factors for who gets the disease. But you have to be careful with risk factors, because something can be statistically related to a disease without causing it. But sometimes the risk factor is statistically related because it does cause it. So it's useful to look at it, but it's not a guarantee that you found the cause. So the strongest risk factor for Alzheimer's is getting old. So we saw that before, that at age 65 your risk of having it is about 1%. At age 95 it's about 50%. So that's a very strong risk factor, advanced age. Family history, and we've already talked about, is another risk factor. Some interesting ones are low education levels is a risk factor. So the fewer years of formal education you have, the more likely you are to develop dementia in late life. That's been replicated in a number of studies over the years. And even further, there's some thought that if you have intellectually active jobs, or if you keep yourself intellectually active, so kind of a use it or lose it phenomenon, there seems to be some effect, either protective or as a risk factor, depending whether you use it or lose it. So that's, and one of the hopes is that because the proportion of people that get at least grade 12 and the proportion that go on to university of people has been going up for the whole last century, that may be one factor that reduces the risk for the generations now entering old age. Against that, though, is the fact that we're mostly too heavy and have too high of blood pressure, and that might erase the advantage we got from being more educated. Another one that's just in the news right now is head injuries. So the head injuries can be from any cause, but what's in the news is the sports-related concussions. And that's definitely a risk factor for dementia in later life. And so they're right to be looking at that. And they should be changing sports so people get fewer head injuries. Down syndrome is another genetic relation with Alzheimer's disease. Down syndrome is a genetic disease, and it's related to chromosome 21. And one of the family genes from that autosomal dominant thing we talked about earlier, one of those genes is on chromosome 21, but not all of them. So there's a genetic link there, but it's not direct. People with Down syndrome are at risk of developing Alzheimer's much earlier in life than people without Down syndrome, so sometimes in their 30s or 40s even, although certainly not everybody. There are environmental factors as well that can be a risk factor. Aluminum was one that was looked at for a long time. There's aluminum in those plaques, but at present people don't think it's a strong, like it's a cause, although since we don't know 100% what the cause is, it might come back. And we don't know for sure any definite other environmental factors at this point. So on to just a brief mention of some of the other causes of dementia besides Alzheimer's disease. So probably the second most common cause is vascular dementia, and that just means dementia caused by strokes. And a stroke is losing blood supply to an area of the brain. It's usually a little blood clot or something that breaks off from another artery or from your heart, drifts up your blood supply, and lodges in a tiny artery and blocks that area. So the part of the brain that's just lost its blood supply, if it doesn't reopen fast, that part of the brain dies, and that's a stroke. And if it's a big area, then it's a bad stroke. If it's a little area, it's a small stroke. One of the things that can happen is you can have numerous small strokes, not even know you had them, and altogether they can add up to memory problems and dementia. The things that cause strokes are well known. That's high blood pressure, too much salt, diabetes, smoking, some heredity, and so on. And those, we do know at least how to reduce the risk of having strokes. Manage your blood pressure, control your diabetes, quit smoking, take an aspirin, and so But once the vascular dementia is there, we can't cure it or put it back. The classic picture for vascular dementia was said to be stepwise deterioration, where a person's going along okay, they're suddenly worse, and then they're okay for a while, as opposed to the gradually progressive pattern of Alzheimer's. But not everybody that turns out later to have vascular dementia has that clear stepwise picture. And really the diagnosis now is made by history. If you know you've had strokes and now you have memory problems, especially that started right when you know you had a stroke, or if you have memory problems and you have evidence on physical examination of a stroke, or with all the imaging, the CAT scans and the MRIs, they can see the strokes. And that's quite often how we pick up the vascular dementia now. And not everyone that has lots of strokes had this stepwise pattern. Now, strokes are common and Alzheimer's is common, so it's not that uncommon to have them both. And if you have them both, it's called mixed dementia. I know that's fancy terminology, but I know you can handle it. You can actually have mixed dementia with the other types of dementia as well, if you're particularly unlucky. And the more they look at Alzheimer's disease, the more we wonder if some of it isn't actually vascular dementia, especially in the old people over 80 and 90. But that's still an area of active research. But there's certainly at least some people with both Alzheimer's process and they've had strokes. And of course, it's worse to have both than just to have one or the other. And as I said, we can prevent strokes, although we can't put the brain back if it's already damaged. A whole another kind of dementia is called Lewy body dementia. And it looks kind of like Alzheimer's crossed with Parkinson's disease. And you can actually get Lewy body dementia after you've had Parkinson's disease for a long time. Or the Lewy body dementia can come along first and the Parkinson's symptoms can be minor or secondary or even come later. The differences between Lewy body and Alzheimer dementia are that people with Lewy body fluctuate from day to day more. Now everybody, whether you have dementia or not, has good days and bad days. And that's certainly true in Alzheimer's disease. People with that have good days and bad days. But people with Lewy body can have really good days but then really bad days, where they're very disabled and confused, maybe hallucinating, even agitated on a bad day. And on a good day, they're pretty good and you would doubt they had the dementia. So that's what we mean by more fluctuation. And they certainly may well have Parkinson-type symptoms. That's not necessarily just the tremor. The other things that Parkinson's includes is slowing your movements down, trouble walking, rigidity of the muscles. Anybody with dementia can have hallucinations, but people with Lewy body are more likely to have them. So frontotemporal dementia is another different kind that's sometimes called Pick's disease, but the preferred name now is frontotemporal dementia. That's talking about the area of the brain that it affects most. So the frontal lobe is at the front, the temporal lobe is here behind your temple. There's two other lobes, the parietal and occipital. So this dementia affects the front part, which controls, among other things, personality and behavior. So people with this dementia can have a lot more behavior problems than they have memory problems. But on the other hand, Alzheimer's disease does affect the frontal lobe. So having these behaviors doesn't clinch that it's frontotemporal dementia. Right, so I mentioned we would talk about some of the other symptoms later on, and that's now. So here we go. So it doesn't just affect your memory, it affects other aspects of thinking. So it does affect memory, especially Alzheimer's and the other degenerative dementias, less so in frontotemporal. And vascular dementia depends where the stroke is. So it can be a lot of your memory, or it can more be slowing of your thinking and problems making decisions. So learning new things and making decisions we call executive function. That also lives in the frontal lobe. Memory, we saw a picture of that at the bottom. That's actually part of the temporal lobe. If you have memory problems, that can show up as misplacing things, repeating questions over and over, just forgetting anything, appointments or anything else. It's usually worse for recent memory than it is for long-term memory, although it does affect the long-term memory. And if you test a person's long-term memory, if you know the same things they do, you may see changes if you put them on the spot. Not that you would do that on purpose. And then as it gets worse, it affects more and more of the person's ability to function. Can affect your language function. So we're just going to talk about a few of those specific neurologic symptoms just for more clarity. So there's a technical term called apraxia that means a loss of ability to carry out a complex action that's not due to weakness or some other neurologic disability. And it's hard to understand from that definition, but examples tell you what it is. So what this really is as you learn to do things first as a small child and a toddler, and then as you progress through life, there's a lot of things you pick up and learn, and once you learn them, you stop thinking about them. So that includes basic stuff like dressing and going to the bathroom and brushing your teeth. So you may think about what to wear, but once you've got it, you don't think about how to put it on because your body just knows how to do that. Well, that's praxia. So if you have problems with that, you can forget how to do those things that you always know how to do. So it can affect, you can have dressing apraxia. That's more in moderately severe dementia. In a mild or early dementia, it would be the stuff you learn later. So maybe aspects of cooking or handiwork or driving or something that you learn later in life. And as it gets worse and worse, it can affect the more basic things. Agnosia is another neurology jargon. It comes from the same word as the word recognize. So agnosia and recognize. And so that's the place where your brain stores patterns of things that you recognize. So either visual recognition, or there's also tactile recognition, so things that you touch. So people that have problems recognizing may not recognize people that they do know, and it's because of this agnosia. Or they may not recognize places that they know. And one consequence of that is somebody says, I want to go home, but they already are home. And that can be because they don't recognize their home as home. Sometimes people won't recognize themselves in the mirror and might misinterpret to be a stranger or their mother or father or something like that. And the quote there at the bottom, the man who mistook his wife for a hat, that was the title of a book by Oliver Sacks. He's a neurologist, and he was describing a man who had a stroke. He had agnosia as his only deficit from that stroke. And one morning, instead of kissing his wife goodbye and taking his hat off the hat rack, he tried to kiss his hat goodbye and take his wife's head as the hat. And that was because of his agnosia. The two vaguely hat-shaped objects were indistinguishable to him. So that's an agnosia. Aphasia is a language deficit, so that's as if you've forgotten how to speak your own language, and we subdivide it into receptive aphasia, whether you can understand what you hear or read in your own language, and expressive aphasia, where you can't put your own thoughts into your own language, either spoken or written. And people with Alzheimer's disease especially tend to get an aphasia. It tends to be more the expressive side than the receptive side, but it does affect both. So early on, it might just be more problems finding the right word. So everyone does that now and again, and again, that doesn't mean you have dementia next time you forget a word. But if it happens more and more, and if it's to the point where it's affecting your ability to say what you want to say, then it could be an early symptom of dementia. You can certainly get aphasia from a stroke. That's one of the classic presentations of a stroke, either a receptive or expressive aphasia. But if it's coming on gradually over years, it's more likely one of these dementias, either Alzheimer's or some of the variants of the frontotemporal dementias. And again, with Alzheimer's, it's a progressive disease. Early on, the symptoms are mild. As it gets worse and worse, it can affect the person's ability to communicate at all. I talked a little bit earlier about the frontal lobe, and that's where personality and behavior and social awareness, things like that, are located. And a person that's having trouble with their frontal lobe can have a variety of different symptoms or all of the above. So one of them can be apathy or lack of initiative. So that's where our get up and go is. It's in our frontal lobe. And if you have problems there, you just may not have any. There's other things that make people not do anything. Depression is one of them. People with depression are sad as well as apathetic. People with dementia may be apathetic without being sad, but it's something we have to look at whether it's the dementia or there's a depression as well. Some people become more labile, meaning their moods and emotions may fluctuate, become harder to control. Sometimes it can be agitation or even anger and aggression. It's not always that though. And some people can become paranoid or suspicious. It can make the person's personality seem quite different from what they used to be, but that also doesn't happen to everyone. Some people just become a lot more like they always were. It can change in either direction. Angry person can become quiet, or a quiet person can become angry, or they can stay the same as they were. It's really hard to predict until you're there. And certainly a lot of those behaviors can be quite challenging. One of the approaches is to try and think what it is, why they are that way, and trying to put yourself in the person's shoes. If I had the same problems with memory and I didn't recognize me and I didn't recognize where I was, how would I feel? Pretty anxious and upset, and try and address it that way. I think some of the other sessions will be talking about that. And so these are a list of some of the behaviors that can happen. And again, not everyone gets no one gets all of them. And some people go through the whole thing really not having got any of them. Most people get at least some of these behaviors at some time or another. But it's not as though everyone with dementia is doomed to have all of these behaviors. But obviously some of them can be quite difficult. The anger, agitation, inappropriate sexual behavior, physical aggressions, those are all hard to deal with. Delusions and hallucinations that aren't always hard to deal with, but certainly can be. I think I already said that. They may make you more like you always were, or they may make you different than you used to be. It's hard to predict. As dementia progresses, it starts by affecting just the complex functions first. So things like managing finances, that some people, I guess, never really get the hang of. Driving, cooking, other stuff that requires equipment, what we call instrumental activities of daily living. As it gets more severe into the moderate and severe stages, it will eventually affect your basic daily tasks like dressing, bathing, going to the toilet, feeding yourself. Incontinence is pretty common just on its own, separate from dementia, but dementia eventually will make a person become incontinent if they weren't before. That's not till the later stages though, incontinence caused by dementia. And then walking is one of the later things usually to go, unless you had some other problem with your walking before that. The severe stage of dementia is no fun to contemplate, because it eventually does affect every aspect of functioning, and eventually makes people unable to walk, really communicate clearly. But exactly how long a person has before they might get to such a stage will vary from person to person. And especially early on, these severe, difficult stages aren't the case, and lots of people can have a fairly well preserved quality of life, especially in the earlier stages. Even if a person's stuck in bed and having trouble walking and talking, we still think there's the touch and the sound of the voice that people respond to and can be calmed by. So I think even at every stage, there's things people can do, but it's certainly not fun to contemplate at all. The caring for somebody with dementia is quite demanding, and it gets more demanding on average as the dementia progresses. In the early stages, many people or most people can remain in the community, often with help. As you get into the moderate stages, more people get so hard to look after that they have to consider moving to a nursing home. And in the severe stage, the majority of people are in the nursing home. It often becomes just too hard even for the most devoted caregiver to manage. It all depends on each person's individual circumstances. We've got the home care and other things that people can have, but so a little bit on to making the diagnosis. The short description of this is that it's a clinical diagnosis. We still don't have any test that proves whether you do or don't have Alzheimer's disease, or for that matter, any of the other dementias. As I said, we can see strokes on CAT scans and MRIs, so that helps make the diagnosis of vascular dementia. But there's no scan for Alzheimer's and no blood test. So how we make the clinical diagnosis is we ask about all those symptoms I've just described. We always need collateral history from somebody who knows the person. It's usually a family member, friends, or someone who either lives with them or at least knows them well enough to help out. Part of that is because dementias often affect the part of the brain that allows the person to understand that there's something wrong with them as well. So not only might they forget that they forget, but it can affect the very ability to recognize that there's something wrong with you. So the person's history, you can't just trust that, unfortunately. So we do need the collateral history. We certainly need to know what medical and psychiatric trouble people have had and what medications they're on. There's a lot of things that can either contribute to it or relate to it, and there's medications that can cause memory loss. We need to know when it started, how long it's been going on, whether it's been getting worse, and we have to know if it's affecting people's function, not only to make the diagnosis, but also then to say, well, what do we need to help them with? What things can't they do, so we need to make sure there's help for them to do that. I mentioned earlier about looking for depression, because depression can look like early dementia and vice versa, and you can have both. So we do need to look for that always. Depression has more effective treatments available than we've got so far for dementia, so we really need to know if it's there to try and treat it. Delirium is sudden change in cognition or memory and thinking, and quite often that's caused by an acute illness of some sort. there needs to be at least a reasonable search for whether they're sick with some kind of infection or change in their blood chemistry, or maybe they did have a stroke. Maybe we just put them on a medication that's made them confused. We do take a measure of people's cognitive status by history, so do they have memory symptoms and is it affecting their function? But we also do at least one formal test or objective test. The most commonly used one is the mini mental status exam, the MMSE. It's scored out of 30. It has questions about orientation to place in time. You have to remember 3 words. You have to spell world backwards and so on. And this is to test people's memory, orientation, concentration, and it's got tests for aphasia on there. So that's why we do that test. There's other ones though. There's one that's called the MOCA now, the Montreal Cognitive Assessment. It's kind of looks like the mini mental, but it's harder. It's also scored out of 30, which is confusing. But a poor score on that one isn't as bad as a poor score on the MMSE. We do a physical examination, partly looking for signs of strokes or other diseases that aren't Alzheimer's, but also looking for Parkinsonism, and if the person's just sick and that's why they can't remember. I mentioned that there's a number of medications that can make your memory worse. Most of them are doctor's fault, prescription medications, but some of them are actually available over the counter. So anything that's marketed as a sleeping pill is not good for your memory. And over-the-counter antihistamines, the drowsy kind, and they may be marketed for colds, allergies. Gravol for nausea is also an antihistamine, as well as sleeping pills. So those are all bad for your memory, and people with memory problems shouldn't take them. There's a lot of prescription pills, and I've just given you a partial list there. So one way in which medications can affect the memory is by being anticholinergic, and that will come back in the next couple of slides. That basically makes them the opposite of memory pills, because memory pills are cholinergic. Again, that's not on the test, because there is no test. And there's a lot of different pills that can be anticholinergic, so some but not all antidepressants, most antipsychotic medications. The antihistamines, like I mentioned, can be prescribed as well as over the counter. Some but not all anti-Parkinson drugs are anticholinergic. All the medications for overactive bladder are the opposite of memory pills, so it is an important question what pills the person is on. And any drug that makes you sleepy is not good for your memory in general. So narcotics, sleeping pills make you sleepy on purpose. Anti-anxiety pills are anything that ends with azepam, and so on. There's other ones. We often do some laboratory tests. That's not to diagnose Alzheimer's, that's to look for other things. So if you had very severe anemia, that could affect your memory. If your diabetes was completely out of control, especially if you were getting low sugars, but severe high sugars and the other blood chemistry problems. Hypothyroidism, low thyroid, can look like memory loss. And vitamin B12 deficiency is very common. In theory can cause dementia, but although we find deficiency all the time and replace it, unfortunately we hardly ever cure a dementia, or never, unfortunately. As I mentioned, we might do a scan. That's not to rule in Alzheimer's, it's to rule out or look for strokes. And there are other investigative tests. A lot of them do suggest that it's an Alzheimer's versus a Lewy body dementia, but none of them are cut and dried yes or no tests, so that you can do a lot of other tests, but you still end up having to make a judgment call, usually based on the clinical presentation anyway. There are pills, there are memory pills for Alzheimer's disease, but I mentioned at the beginning that's not the most important part of the management, because the memory pills aren't as good as we wish they were. So the other things, as I just mentioned, we have to look for and treat contributing factors. We have to assess the person's function and make sure their needs are met and that they're safe. There is some benefit to memory aids and coping strategies like memory books and routines, and well, everybody uses some kind of calendar or electronic auxiliary brain to keep track of their schedule somehow, but formalizing some of those can be beneficial as an adaptive strategy. Advanced care planning is important, especially with early dementia, because it's quite possible for it to become too late to do a power of attorney and a living will, so you have to do that early on. And then there are pills for dementia, so I'll talk about them. I just covered all of that. So the medications you can divide into two broad groups: cognitive enhancers or memory pills, and medications to treat the behavior and mood complications of dementia. So the first memory pill on the market in Canada was Aricept. Its real name is donepezil. And how it works is it's a cholinesterase inhibitor. And what's that, you might ask? What it does is increase the level of acetylcholine in the brain. Acetylcholine is a little chemical that the brain cells use to communicate with each other. They don't actually touch each other. There's little gaps in between, and they shoot these chemicals across the gap. So for the memory cells, they use acetylcholine, and that's why it was targeted as a memory pill. And that's why anticholinergic drugs are bad for your memory. So it's that same acetylcholine thing for memory. So they did come up with these drugs that improve the amount of acetylcholine available in your brain, and gave them to people with mild to moderate Alzheimer's. It did cause some side effects for some people: stomach upset, vomiting and diarrhea. Only 5 or 10% of people that try it can't tolerate it at all. A third get milder side effects. Often they can just get used to them and they stop occurring. So that's a little schematic of the end of a nerve cell next to the end of the start of another one. The little green dots are the acetylcholine molecules. The purple things are the receptors that they're trying to get onto. So if you take a memory pill, you have more green dots. If you take a drug that's anticholinergic, it blocks the purple receptor. Up till now, the memory pills have been quite expensive. The other two have gone generic before, and donepezil just went generic now. So they used to cost over $150 a month. Now it's down to about $50 a month. It is covered by pharmacare, but only if you meet certain criteria. And so what good does it do? On average, groups of people with dementia taking donepezil or the other similar drugs score 1 point better on that memory test than people not taking it. So it is a measurable effect. It's just not as big of effect as we wish it was. Now, that's for groups of people. So among those groups, there will be some people, about 1 in 6, who have a better result, and their score might go up 2 or 3 points. They might really notice the benefit. They and their family say, "Thank you for that pill, it's great." If you're one of those 1 in 6, I also think that's great. Unfortunately, the 4 out of 6 say something like, "Well, I can't really tell if it's helping my family member," in which case we often just carry on hoping it is, and that if they weren't taking it, they would have been worse off by now. And then there is another 1 in 6 left over, and those people may actually get worse when they try the memory pills. So they may well be worth a try. You want to hope you're that 1 in 6 that gets a really good result. But most people, it's hard for them to tell whether it's helping. And for most people, it just kind of helps them stabilize for a while. The drug company likes to advertise that as delaying the progression of the disease, but that's really an overstatement. What it is a symptomatic treatment that makes your memory look like it stabilizes for a while. But there's no proof that it actually affects the underlying condition, unfortunately. The cost effectiveness is less controversial now that it's generic. That's a joke. Hey Ed, I found out why my prescription costs so much. So there's two other memory pills. They're really quite similar to Aricept. Their brand names are Remenil and Exelon. Their real names are galantamine and rivastigmine. If you're a farmer, you may recognize galantamine as an insecticide. Don't worry. These are smaller amounts of galantamine. And they've certainly been proven to have the same effects as Aricept, modest benefits on memory, possibility of stomach side effects and other things. They started out being taken twice a day, but since then they've come out with once a day formulations of them all. They all cost the same. They're basically the same. They're not the same chemical, but they may as well be. The first studies were done in Alzheimer's disease, but they appear to have about the same benefit in vascular dementia, mixed dementia, and Lewy body dementia, not in frontotemporal dementia and other ones. There's a whole different kind of drug called Ebixa. Its real name is memantine. It has a completely different mechanism of action, and I have no idea why it should improve somebody's memory. So you can see there it has something to do with glutamate and this NMDA receptor, whatever that is. But how that improves people's memory, nobody can explain to me. But in some of the studies in people with anywhere from mild to severe dementia, it did have small, modest benefits, kind of like the cholinesterase inhibitors. It's got even fewer side effects. I'm just not convinced it does anything. If it is used, it's more suggested to be used in moderate to severe, where the studies were more reliably showing a small benefit. It's not covered by pharmacare. Many other drugs have been tried, many hundreds. But those are the only ones on the market so far. For herbal preparations, people talk about ginkgo biloba, which actually comes from the leaf of an ancient tree, a prehistoric tree that's still with us. They have done proper randomized controlled clinical trials with ginkgo biloba extracts. If it does anything, it does even less than the prescription medications. So it may do some tiny amount, but it's really hard to say how important that benefit would be when it's hard to tell what the prescription ones do. It really doesn't have any side effects, although there's something about bleeding, so if you're on blood thinners, I wouldn't take ginkgo if I were you. People talked about vitamin E. It's an antioxidant. There's been great enthusiasm about antioxidants as preventing every disease. It's been harder to show that that's true, though, than the theory. One early study showed that a huge dose of vitamin E either did delay the need for a nursing home or didn't. So there was problems with the study. And a subsequent study didn't show any benefit. And more recently, people worry that these megadoses of vitamin E might be bad for your heart and kill you. So it's not recommended now. If you're going to take vitamin E, I wouldn't take more than 400 units. I don't really think there's any compelling reason to take any. People have looked at estrogen and anti-inflammatory drugs. They were statistically associated with lower likelihood of having Alzheimer's disease. But when you give it to people on purpose, trying to prevent Alzheimer's or treat it, it makes them worse, not better. So they're not treatments or cures or preventive measures. I'm now 1 minute over, so I'll just quickly mention that there's a lot of theories, a lot of research going on. They have tested some of these theories on this slide already, and unfortunately the initial studies have flunked out again, but nobody's given up yet. And then just very briefly, that's the memory pills. If people are depressed, we can try and treat that, and if people are agitated, we can try and treat that, but the drugs for treating agitation have a lot of side effects. So we try to hold the drugs as a last resort and do everything else without giving people those medications, just because the medications have so many potentially severe side effects, like even increased mortality. The behavior are seeing if there is anything causing it. Are they really hungry or constipated or in pain? Can you distract the person, change the subject, do something else, keep them occupied? Can you lock yourself in the bathroom for 2 minutes and they'll be okay because they'll have forgotten what they were mad about? All of these are possible strategies. But some people are just so agitated that we have to give them medications. They just should be used with caution. So, I think we made it.